Now, I'm going to talk a little bit about patient-simulated tasks when you do counsel patients. Usually what they care for is that it has to be a patient-centered approach, meaning that you're involving the patient more in your discussion, no matter what the case scenario is. Even when you're taking history, it has to be a patient-centered approach. When you're explaining test results, it has to be a patient-centered approach. When you are talking about management plan, it has to be a patient-centered approach. And how can you apply this? First of all, develop a rapport with the patient, a relationship, just by simply greeting her. If you're not going to break bad news, hi, my name is Ofa, I'm one of the doctors here, good afternoon, how are you doing? Or if it's a normal case, let's say a case of just coming in with discuss contraception, for example. Okay, if she's wearing a nice dress, I really like your outfit, it's colorful, you know, try just to find a way to develop a rapport with the patient. At some point, and not all of the cases, you empathize and provide support, even if she tells you a story along the line just randomly about she had to take her dog to a vet, the dog is not fine, empathize. Her mother died before, empathize. Okay, if she was complaining that the pain is too much, she can't handle, let's say it's chronic pelvic pain, empathize as well. Okay, involve the patient throughout the consultation. It's always a give and take, checking she's understanding, like chunking and checking understanding. Some people ask, are you with me so far? Are you following me? Please, I mean, try to avoid them, because you're not, you're by saying that, you're putting yourself in a position superior to the patient, like asking them commands. Are you following me? Are you paying attention? It will be taken that way, although you don't mean it, I know. Usually just ask, does that make sense? Am I clear so far? Do you have any questions? These types of sentences you can use. Give the patient the correct amount of information, and by giving the correct amount is, you, in the exam, you should not mention or spill out everything that is written in the guideline. It's too much for the patient to absorb. Just give her the information that she will need. Okay, if I was a patient, let's say I'm having polycystic ovarian syndrome, what I would like to know when they're discussing the results with me is that, what do I have? I want to understand that. Why do I have it? Is there any possible reasons for me having polycystic ovarian syndrome? And is there any management for it? And if yes, what are the management options? And for each option, I would like to know enough information so I can, you know, agree for it, like how it works, how long am I going to take it for, any risks or side effects. Okay, and at the end, I want to have, what can I say? I want to have the opportunity or option for me to choose if it's something I need to choose, or if it's just one management plan stepwise. I want to be given the option of seeing, do I agree with it? Do I want to take it or not? Okay, and if it's something complicated, you can draw the ovary for me. So that's using visual aid. I would appreciate that as a patient. And at the end, I will just want a brief summary regarding, okay, this is what's going to happen, and if I'm going to be coming in for follow-up or not. That is it. So if you think about it that way for each and every case, that is just the amount of information you give. And I'll repeat it again. Tell the patient, let her know what she has, okay, why she has it, if there's any reason. Is there any treatment, yes or no? And if yes, what are the treatment options? And in terms of the treatment options, is it something stepwise? We start with step 1. If it doesn't work, we go to step 2 and so on. That's usually in urogyne case scenarios. If it's multiple options the patient can choose from, make sure you say, I want to know that this is the first option, what it is, how it works, for how long I take it, if it's medication, and what are the side effects. And then you go on to the next option, give the same amount of information for that, and at the end ask me, what would I prefer? If it's a stepwise, make it clear say, okay, so what we usually take it in a stepwise manner. So usually first step, we would recommend doing 1, 2, 3, 4, discuss that fully with details, because this is the first thing that she's going to receive. Ask her, does that make sense to you? Do you agree for that? If she says yes, tell her, okay, so we're going to start ahead with this. I'm going to give you the prescription for it, and then we'll follow you up in 3 months' time. We'll see how you're doing. If your symptoms have gone away and you're happy, then that's fine. You just continue on it, and we can possibly discharge you to the GP. If still you're struggling with your symptoms, then we can look at the next option, which would be, and you just generally mention what it is. So just let her know the stepwise management plan, what to expect. Either it would work, either it would not work, and if it doesn't work, what is going to happen next in the future. You don't have to go into details about the side effects, the risks, and everything about what will happen in the future. Just tell her, let's say after 3 months' time, we see you, you're still having the pain, then we can discuss with you or start you off on this treatment or medication. If that doesn't work as well, we go on to the next one, which is this. You don't have to talk about side effects or risk. That is too much, and it's not enough for the 10 minutes, because you're still maybe having result explanation or having what is it called, history taking. And always when you ask the patient in between, do you have any questions, they will guide you in the exam. Okay, 100%. They won't let you go off track, and each question they ask, there's an answer for that question. They are trained actors. They're not really real patients who just improvise something from their head. No, they have a script to follow. Okay. Sometimes you may need to repeat areas of consultation. Like, let's say you talked about the combined oral contraceptive pill fully, how it works with the side effects and the risks and everything, and then she asks you a question again about the contraceptive pill. Repeat it again, no problem. Answer her question. Okay. And it has to be a shared decision making with the patient. Then see what she wants. And in some cases, you safety net. Safety netting is just making sure that there are certain symptoms the patient needs to look out for, and it requires for her to come in immediately before her booked appointment. And that would be, for example, a patient who had a perineal tear. You're discharging her, and then she would have a 6-week follow-up appointment, right? Tell her at any time from now until 6 weeks, if you have 1, 2, 3, 4, please come in immediately. Okay, like if she's having symptoms of wound infection or fecal incontinence. Another example would be a patient who had pre-prom. You're sending her home, she's fine. And then you tell her, we bring you in for follow-up after a week, for example, to check your bloods and everything. During that week, if you do develop 1, 2, 3, 4, which are symptoms of signs of infection or chorioamnionitis, to come in immediately. So that's safety netting. Okay. Another example, if a patient came in with reduced fetal movement and you did the CTG, everything's fine, she can feel the baby move, she's happy. You talk to her about how to count the baby's movement, lie on her left side and see how many kicks and so on. If at any time she's concerned, to call the assessment unit to come back in again. Okay, that's an example of safety. And again, safety netting doesn't have to be in each and every case scenario, only when you think about, okay, there are possible complications that can happen that need immediate management. Okay, and that largely depends on the case scenario. Okay, so for you to be able to understand what I mentioned earlier, and also when you're practicing with your study partner, having knowing what you need to pay attention to in terms of marking them. I just got an example of my feedback or marking list for my student, and you can implement this with your study partner in terms of communication with patient skills. Okay, so like I said, it's all about, we're talking just purely about patient-centered approach, nothing else for the time being. So when you have your feedback points, and it's the same for each and every counseling station, no matter what it is, you tell them, see, did they have appropriate introduction? Or you can ask yourself, did I have an appropriate introduction? Yes or no? You were comfortable I'll do it, just not to confuse you with words, I'll do it the other way around. let's say I'm the patient, I'm the examiner, I'm giving you RT feedback, for example. I'll say, okay, RT, you had a appropriate introduction, you were comfortable. It made me as a patient feel comfortable as well. You did ask about the chief complaint and concerns, and I really appreciated that. We then set an agenda and asked if I agreed. So me and you together, we had a clear roadmap taking things forward regarding what's going to happen during this 10 minutes. I really appreciated the fact that you started off with an open-ended question. You allowed me to tell my story. You gave me that opportunity to share what my problem is. You were maintaining good eye contact. You were actively listening, nodding your head when I was talking. I knew that you were hearing me as a patient because you were paraphrasing. And by paraphrasing, I mean like when you're asking history questions, like for example, did you have any surgical procedures before? And she says no. They say, okay, so no operations. That's paraphrasing, just like reflecting and what they're saying in summary, and also summarizing after the history. That's paraphrasing or reflecting, just to show that you are on track with the patient, you are hearing them, you're understanding that. That's how you're involving the patient and showing her that you are listening to her, also showing the examiner that you are paying attention to the patient. Also, other aspects would be nice flow in terms of your wordings, logical sequence. So you started with this part, with result explanation, then you went to the management plan. In your management plan, you took one option after the other, ensuring that I understood in between. I can also tell you that you were non-judgmental when I said I had multiple sexual partners, or I work as a personal escort, or I smoke half a pack a day, or I am an alcoholic. You do not have to be judgmental at all. Just give gentle advice in terms of support available on the NHS, and then summarizing at the end. Okay, so that's an example of how you should be marking yourself and marking your study partner. Does anyone have any question? Okay, now let's go to examples for result explanation. Okay, and now I just want you to understand that result explanation is not just about telling the patient, okay, this is what you have, this is what your ultrasound scan shows, but rather involving her in the beginning, in between, and at the end. So does anyone want to give it a try? So you have ultrasound scan showing there's a measurement of the uterus, fine. Endometrium is 11 millimeter thickness. This patient is postmenopausal for around 10 years. She's been coming with postmenopausal bleeding. Endometrium is regular. There's a 3x3 subserosal fibroid. Right and left ovary is normal. No masses or fluid in the pouch of Douglas. So our in summary, postmenopausal lady been having postmenopausal bleeding. I was assessed, investigated. Now the scan is out. Who wants to explain to me the result that the endometrium is thick, and telling me why it is, like telling me that the scan in terms of the endometrial thickness is not normal, and what can be the possible reasons, and what would be done next or offered for her to find out the possible reasons. It should not take more than 4 minutes. Anyone wants to give it a try? No one? Okay, no issues. I'll do this one for you. Okay. So again, we're going to omit history taking and the introduction. Okay, I'm going to start with the introduction part. Explain the result, just quickly give an outline, but our main focus is explaining the result. So, okay, so after I introduce myself and everything, I'll tell her, let's say her name is Samantha. So Samantha, good morning. How are you doing today? Do you know why you came in for this consultation? Yes, I had a scan and I'm supposed to discuss the results. Okay, so before we go on to the results, can you just take me through what led for you having the scan done in the first place? So she can tell you that, well, I had bleeding and they told me they want to do the scan. So do you know what they were specifically looking for on the scan? Why am I asking that? Because sometimes that is explained to patients as well. She can say just to look for the lining of the womb, or she can tell you no, just to see if there's any reason. Tell her, okay, that's well and fine. So basically, so let's take a look at your scan. And like you said, the scan was done to see the reason why you're having bleeding. It looked specifically at the lining of the womb and how thick it is. Usually want it to be less than 4 millimeter. In your case, it's 11 millimeters, so it's thicker than we want it to be. That can explain why you're having the bleeding. The other things that the scan looked for was the size of your womb, which was fine. They noted a small fibroid, 3 centimeters, but it has no significance. It's just on the top, on the outer lining of your womb. So it's of no concern. Both your ovaries are fine as well. So having said that, since the lining of your womb is thicker than we want it to be, we would want to investigate and see why. Sometimes it can be just a normal thickening and the cells can be normal. Sometimes it can be thickened with abnormal cells that are not cancer. And in some cases, it may be cancer. Sometimes it can be a small growth we call a polyp that just appears as a thick lining of the womb. So for us to be able to know what is causing that, the next step would be taking a sample directly from the lining of your womb. We can do it in 2 ways. Either I can do it for you now in clinic, that would be through a pupil biopsy, just a small tube. I'll insert a speculum, go inside, and then take some cells. It can be a little bit uncomfortable. So what do you think? Some women will tell you, no, I don't want that. So if she refuses, tell her, okay. If you don't want that to be done, then you can, what we recommend is a hysteroscopy, because at the end, our ultimate aim is to take a sample from the lining of your womb to see the nature of the cells. Hysteroscopy, basically inserting a camera, vaginally as well, no cuts at all, going in inside, taking a sample from the lining of the womb. And also with the camera, we take that opportunity of checking as well if there's any abnormality inside. She can ask you, would you be able to look at my ovaries? Because sometimes patients ask that. Tell her, no, to be able to see your ovaries, you would have to do a keyhole surgery, and that's not what we're going to do at the moment. Then you tell her it can either be done as an outpatient in the office, you're wide awake, you'll just be given pain relief, or you can have it under anesthesia, meaning that you'll be asleep, you wouldn't feel anything, and you will go home the same day. See what she wants. Okay, and if she tells you, well, I want a hysteroscopy, let's say under GA, then you're going to consent her. Okay, if it's a consent. I don't know how it's going to turn out because I just wanted to focus on result explanation, but then that's where you stop and see what they require from you. Do you need to book her in for the surgery, or does she have questions, or are there any risk factors in her case that you need to discuss it with her, that until you have the hysteroscopy done, then we would want you to advise you to stop smoking or reduce your BMI and so on. Okay. So here at the end, in summary, I didn't just tell the patient that you have a thick endometrium. I told her that when you had the scan, this is what we were looking, this is the reason why you had the scan, and this is specifically what we were looking for. And I explained to her that the lining of the womb is thick. I also explained to her the other findings. Patients have the right to know other things that are normal as well. Okay. And after I explained to her that the lining is thick, I told her what the possible reasons can be, and how can we know what the reason is. That would be the next step of management, and then you just take it on from there according to how much other details that you have in the case of what you're required to do. This is another example of a histopathology report. So let's say our patient is okay. Let's say our patient is a young patient coming in. She was coming in with heavy irregular periods, and she had a scan done. It showed possibility of a polyp. So she had a hysteroscopy and polypectomy done. Sorry, I just remembered something. In the previous case here, just since she's postmenopausal and it's a thick endometrium, you're suspecting cancer, and she is symptomatic of bleeding. If you're going to put her on a hysteroscopy list, either outpatient or inpatient, it has to be within the fast track 2-week wait pathway. Okay, because you're suspecting cancer and she's postmenopausal. That would be what they're looking for under safety here. Okay. So she had a hysteroscopy with polypectomy, and they took an endometrial sample and or endometrial biopsy. She went home on the same day. The result came after, usually takes around 3-4 weeks. It came out, and now she's in the clinic for follow-up to discuss the results. She's coming here to discuss the results and see if it was just a polyp, it was removed, and you would ask her, of course, if there's any bleeding, ongoing bleeding from, have her symptoms improved or not since she had the procedure, how was her recovery. Now, if you look at the report, it mentions clinical details: endometrial polyp, nature of the specimen was a polyp, microscopy showed multiple cream and hemorrhagic fragments in aggregate measuring this by this by this. Microscopy showed that the sample is comprised of multiple fragments of polypoidal endometrial tissue, most of them showing features of benign endometrial hyperplasia. There is included fragments of endometrial tissue. 2 fragments show clustered glands with no significant cytological atypia, best regarded as hyperplasia without atypia. So the conclusion is an endometrial polyp that was removed, and when they took the biopsy, or accidentally there were cells with it from the endometrium, it showed hyperplasia without atypia. So here, let me highlight. Where did it go? Your diagnosis is endometrial polyp and hyperplasia without atypia. Now, when you see that result, and then on this case scenario, you'll be thinking, number one, did that patient know that she had a polyp, or it was just an incidental find? Did she know beforehand, before the procedure on the scan, that there's a polyp and there was a thick endometrium or not? And she was prepared for, and she knew that the sample is going to be taken from the endometrium and the polyp is going to be removed. Does she know that? Or she doesn't know? The scan just showed a thick endometrium. She went in to have the polyp removed. She didn't know that she had a polyp. So you don't know what the patient actually knows. And for both of you to be on the same page before you go and explaining, ask her. Okay, and that would be the normal question that I asked before in the previous result explanation. It was that, can you tell me what led to you having the procedure done? Okay, she will tell you the whole story, and she will let you know if she knows that there was a possibility of a polyp, or post-operatively, before she was sent home on the same day, did the surgeon come and counsel and tell her we found a polyp and we took it out? Okay, so just make sure that how much she knows before you explain the result, no matter what the result is. And then after you ask her that, so tell her, how's your recovery after the procedure? How's your bleeding? Is there any improvement, or did you get a period after the operation? And then come to the result. Tell her, after confirming your name and NHS number, So basically, during the procedure, they found a polyp, they took it out, and it was sent to the lab to be tested. The lab did confirm that it was just a polyp, which is benign tissue, it's not cancerous, okay, and it was completely removed. Also, they have taken some of the cells from the lining of the womb. It was tested as well. It did show that you have a condition called hyperplasia without atypia. To explain that further, you can tell her that the lining of your womb was thickened, the cells were growing abnormally, but those cells, in terms of their shape, their structure, they're not abnormal cells. Okay, it's just overgrowth of the cells of the lining of your womb. We call it hyperplasia without atypia. And then confirm with her, does that make sense to you? Any questions? And then you go and tell her that, okay, we've dealt with the polyp, it was removed. Now, the hyperplasia without atypia, this would be a management plan. Okay, and you take it further. So you can see the advantage of you assessing how much the patient knows before you come and conclude and explain the test result. It will help you a lot if she already knows what to expect. And also, if she doesn't know what to expect, then you would know that, okay, I am going to explain to her in details that a polyp was found and what a polyp is, and a hyperplasia was found. Okay, but if she knew beforehand that there's a polyp on the scan, you don't have to explain what a polyp, just say it confirmed that that was a polyp, and that's it. You don't have to waste time and go and explain in details. Okay, does anyone have any questions? Okay, let me see the chat box if there are any questions here. Okay. Someone asked, will the session recording be available in Telegram group? Yes, after a couple of days or within a week's time. We usually upload it to YouTube and Facebook, and we put the link there on the Telegram group. So for you to search us on social media, YouTube or Instagram or Facebook, it's this MRCOG Part 3 circle. Just type it down, just click join, and you would be approved. Okay. For Telegram, those who are not there, you will be sent on the follow-up email. You'll be sent the link to join the Telegram group. If you'd like to contact us on any of our emails, these are the two emails. Usually the Gmail is more active. We do have our website on info on Cokisco, where there are videos as well there in terms of free sessions, but we're currently migrating to a new website that is under process at the moment. So once it's ready, the new batch, which is going to start on July, you're going to be on that platform. Okay. You're not going to be on my hub on Cokisco, but if you want any information, you will find it at cokisco.com. Just click on part 3. You'll find there part 2 by Professor Conji, and then you'll find my part 3. You can just go and read there. You'll find there's a few videos that I've done as well. There's a very nice session with Professor Conji and me there as well. Listen to it. He gave really, really good advice. That was around, I think, 2 years ago. Okay, and I would recommend, please, not because I did take part in writing that book, but it's a really good book. The cases are really good. The tips and advices there are really good. the points that are written there, and in terms of understanding the exam, it's really good. It's the complete revision guide for MRCOG part 3. I've also written a chapter there in terms of how to prepare for the exam, okay, given a few examples. And also at that point, because you know Professor Conji is a fetal medicine specialist, the fetal abnormality is really, really beautifully explained, and what questions you can expect from patients. So it's a really good book that I would recommend. We also have other books. There's I can't really remember them because I don't really go through them, but there's lots of other books that you can find cases from. You don't just have to restrict yourself to the cases in courses or in recalls, books as well. You can use them as one of your resources. Kavita asks, thanks a lot for the great and clear saying. Thank you so much, Kavita. When are we starting? I have put the schedule, Kavita, for the next batch, which is batch 23. I usually conduct one batch only prior to the exam. So that's one batch only, batch number 23, just before the November exam. We're going to start on July. The reason that I haven't opened registration yet is just that the website is under construction, but we are trying to generate the links, the payment links, so people can register early on. But don't worry, all of you who have been in contact with me, I do have your names. They're there, so you do have your slot there. In a few days, I'll send out the schedule in terms of the 16 sessions, when they're going to be, which dates and times, is for all of you to have an idea before we actually start the course. I'm really sorry we're taking a lot of time. It's just that because the website is getting ready at the moment. Okay. Saba asked, how about Oxford? Oxford is a really nice book. It's good. The cases are good as well. Go through that. Lisa Joyle is perfect because it's been put by the Royal College, and in terms of the examiner comments on the markings, they really write down what they would expect from you. It doesn't give you the exact answer per se, but it shows you what you need to cover or what they're looking for. So it's a nice book as well. Saba asked, do you conduct mock exam? When would it be? Yes, I do mock exams usually the last month before the exam, but it largely depends upon, because during my preparatory course, which usually ends a month before the exam, it depends upon how many special listener candidates that I have, because special listener candidates have individual sessions with me. So if I'm really fully booked, I may not be able to conduct mock exams. But if I do have some time left, because I'm working as well, if I do have some free time, then I do open slots for mock exam. But that, since the exam is in November, it's going to be on October, not before that. Okay, so thank you everyone. I hope you enjoyed it. Please try to apply this, and I'll try to do a free session as well next week. I'll try to choose some specific topics to talk about. Okay. Okay, everyone, thank you so much. And again, you'll receive emails regarding the links to join if you want to join the groups, so you can be updated about any activity that we do. Okay, and don't forget, please watch the YouTube videos. They're going to help you a lot if you haven't. All right, okay, thank you, everyone. Bye, have a good evening.